Hello everyone, and welcome to our 15th seminar series from Single to Mingle in just under 30 seconds, the how-tos in deciphering the dating code. We will be covering addictions within relationships. I'm very excited as our televised seminar won the Monty's Award for the Best Produced Show in the Educational category in 2017, as well as the Best Host Award in 2018. The Monty's Award recognizes producers who constantly bring in creative content in different categories for TV shows. It's like the Academy Awards for producers. My mission is to continue providing great, valuable content to my audience, the viewers at home, and of course, invite the best of the best guest panelists in the DMV area. All this couldn't happen without the help of my amazing TV crew at the studio. Thanks to you all. Now, in our seminars, our guest panelists and myself work very hard in covering all topics related to dating and relationship in the 21st century, and primarily focusing on providing you with the tools needed to be successful in your journey to find your soulmate. My name is Dr. Dan, and I'm your host for today's seminar. I have a doctorate degree in organizational leadership and communication with a minor in quantum physics. I'm also a practicing therapist covering issues such as self-esteem, NPD cases, anger management, and also do marital and relationship counseling. I do individual and group therapy as well. Now, for more information, you can contact me at the number below. Now, it's time to introduce our guests for today's seminar. All experts will have the time to share their expertise and education with our audience and all of the DMV residents. Now, welcome, ladies and gentlemen. Now, could you please tell us a little bit more about yourself, and we'll start with Bob.
Dan, thank you for having me here. So I'm a communication consultant. I wrote a book on communication that came out in 2015. And communication is really my platform. I don't think that we effectively communicate here as individuals, as businesses, and really my message is what happens when we don't communicate effectively, the breakdown in relationships and other things. And so that is really the platform for me is communication.
The cause and effect.
Cause and effect.
Maureen.
Thank you so much for having me here today. My name is Maureen Rao. I'm a practicing therapist at Neuroscientific Insights in Rockville, Maryland. I counsel individuals, couples, and families with issues ranging from depression, anxiety, grief, addictions, trauma, and family issues.
Mostly drug, alcohol, sex, everything?
Everything.
Okay.
Yes.
Good. Dr. Ash.
Dan, I'm Dr. Ash Dewan. I'm board certified in family medicine, but I later got very interested in addiction and chronic pain management. So I certified in those as well. And thank you for having me here because we're here to talk about the opioid epidemic, but there's also a crisis in chronic pain out there. And so I think it's important for people to understand and what people are going through and how we can, as physicians and as lay people, help to solve this crisis.
Perfect. Well, thank you all for being here today. And we're going to get started. So I'm going to ask a question to all of you. Now, it doesn't have any order, so you just go and answer. And you could also either agree or disagree. So let's start with you, Dr. Ash.
Sure.
Now, why are we in this predicament regarding opioid epidemic, and how did we get here?
It's a great question because I think most people don't really understand the rationale. For many years, for almost 100 years, we didn't use opioids much for pain or otherwise. And it wasn't because, most people don't realize, but in the late 1800s, most opioids were banned because so many people were addicted to morphine. Believe it or not, 400,000 Civil War veterans became addicted to morphine after the war. So Bayer Pharmaceutical had come out with an alternative called diacetylmorphine. The brand name was heroin, to be more safe than was morphine. So actually that was a complete catastrophe. So in the early 1900s, the government decided we're going to ban opioids pretty much altogether except in extreme cases. So for 50, 60, 70 years, we didn't use opioids much. And actually that was to the detriment of many people who suffered from chronic pain. So long story short, in the late 80s, there had a couple of studies came out that showed that maybe this idea of not using opioids was a little bit overdone, and that people were needlessly suffering, and if used in the proper manner, that it could be safe. Then there was a report come out in the hospitals by the Joint National Committee, JNC, that came out and said that pain really should be considered as a fifth vital sign in the hospital, and docs were not doing a good enough job treating patients in the hospital. Well, anytime you correlate patient satisfaction with physician approval, that creates a problem. And that was just around the time that OxyContin came out and aggressive marketing by companies. So guess what? The idea that it's a lot safer than it should be, they're not being used often enough, patient satisfaction isn't being met, physicians started prescribing more and more and more opioids, which really continued all the way through 2011. Most physicians are not trained in what the physiology of pain medicine is and how to use it, and that contributed to the problem as well as the marketing by pharmaceuticals.
Very, very detailed. Thank you so much. Now, I know, Bob, you just lost a son just recently in January 21st, 2019. And I know, my condolences to you and to your family. And so how can you apply when it comes to tough love, in relationships, et cetera, and when those who are dealing with addiction, what's the middle ground?
Good question, tough question. I think in this case, and as we dive deeper into this, and I appreciate Dr. Dewan's historical perspective because I think it's very important, and I think a lot of people don't know the historical perspective of how did we get here, because that was your question, how did we get here? He framed it up perfectly. I think when it comes to tough love, it doesn't work in the case of these types of addictions because, and as Dr. Dewan, I know we'll go on and talk about, the altering of the brain that goes on, it's not a matter of saying, pull your big girl panties on or put your boots on or pick yourself up or you're not strong enough or you're not whatever enough. That does not apply here. There are a lot of things, as we can all Monday morning quarterback, I would go back and think of things I would have done differently in Zach's case. And some of those things, I know that he would be here if we had done them, if those things had been available to me. What we're trying to do collectively is raise the awareness and educate. And you have to have a historical perspective to educate. So what I would say, to answer your question, long-winded answer your question, is tough love in isolation doesn't work. It's not a matter, we've got to look at the comorbidity of what's going on, the trauma, and I'm sure Maureen will talk about that as well, the trauma that goes on because most of these people, if not all of these people, experience some kind of trauma in their lives. And that's what we need to look at, and that's where we fall very short. We just, the term, the whole aspect of junkie under the bridge or whatever, or let them go and, toughen up and all that, it just doesn't work. It just doesn't work. And I've paid the ultimate price now for telling you here that it doesn't work.
Now, in your I would say, mission or journey in bringing awareness, as you're using your TV show, the Bob Bass Show, what challenges do you think you face against all the pharmaceutical companies?
Well, that's a big problem, and we could do another show on big pharma, the FDA, government. When you look at the contribution that big pharma makes to political campaigns, about $500 million. You look at how big pharma funds the FDA, about $1 billion. There's a lot of conflict here. There are a lot of there's a lot of conflict of interest here, and again, it comes back to awareness. People don't know what's going on, and we really need to educate the population, and that's really what I'm going to do. Dan, it's so easy to get stepped and splintered into. Everybody wants to sort of coalesce. I've got to pick and choose my battles because it's an enormous battle, and what I've decided to do is treatment and recovery, and Dr. Dewan and I have talked about collaborating and doing some things. We need to raise the public consciousness of this whole thing, and that's really my mission. I'm trying to be somewhat myopic and focus on this is all I can do and go after that, because otherwise you're just all over the place and really accomplish nothing.
Well, thank you. Maureen, I know that you're dealing with families, couples, etc. when it comes to addiction. Now, do you use any holistic approach to your practice, or how you guide your patients to try to avoid going into taking any pain medication and try to do it naturally, try to like meditation or doing whatever else that you would suggest? What is your approach?
Yeah, my approach for all of my clients is to be holistic about it, because I want to know everything that's going on in their life. There may be some things that are going on, what they may have been eating contribute to their emotional well-being. What is they're doing during the day? Are they exercising? Are they getting out into the sun? Are they really taking time for a lot of self-care for themselves? And most of them are not. A lot of these clients that I have that are depressed and they have anxiety, they close themselves off into their little protective space. And the best thing that I tell them to do is you've got to start moving. That is the number one thing. And I do incorporate meditation, and meditation's difficult for a lot of
It is,
people
yes.
because it's hard to sit still being quiet for
50,
you know,
yeah, a few minutes.
And
Yeah.
I tell them, like, go on. I found an app called Headspace, and the
Okay.
meditation is 3 minutes long, and just have them do that every day. And there's, you know, like a 10-day series where they can just try it out. A lot of clients, and I have tried it myself. It calms the mind and really balances out. I have my clients doing yoga.
Okay.
I have them going for acupuncture for a lot of the pain that they may be having, and it really helps with a lot of like depression and anxiety as
Have
well.
you suggested positive affirmation therapy, which is, you know, listening to
Absolutely.
affirmation words, etc.?
Yeah, I have
Okay.
some of my women clients, I have them writing on their
Yes.
mirrors with lipstick in the morning, you know. But it's just, you know, finding out and like really looking inside and finding those things about yourself that you really, you know, are missing, and that you've lost yourself, and just getting, you know, the old you back.
Do they feel more about opening up to you? Because, you know, because some people are so used to, okay, just prescribe me something, I'll be on my way. But the fact that you're trying to go holistically, do they say, well, it has not worked after a week or 2 weeks?
Right.
We know that it takes several months for it to work. Do people
Yeah.
lose patience?
It's really difficult because it's hard for people to open up and trust, especially a stranger, you know, and they really need to know that they have that safe space where they can talk about anything without judgment.
Okay.
And yeah, it really works, you know. They just have to kind of give it time,
I agree.
you know. But I in my practice, I like to laugh a lot with my clients. I like them to look forward to coming every week, you know, and make it like a really productive session for them, you know, because all of these things that everybody goes through, they're born out of something, you know, and we need to find out what the triggers are and then how to just manage it.
Marie makes a good point. You know, I think if you look at that from 30,000 feet in the air, it's about wellness. What she's talking about is wellness, and looking at alternatives to traditional, you know, medicines, and you know, look at, and I'll throw the name out there. Look at Purdue and look at OxyContin. You know, their whole marketing campaign was to keep people addicted from cradle to grave. You know, let's get people addicted, and then let's give them what they need to stay addicted. You know, as opposed to getting out. She talked about sunshine and,
Yeah, vitamin
and
D, a lot
positive
of people
thinking and
lacking,
vitamin
yeah.
D and all these things like that, all these holistic things that I think other cultures have been, the Chinese, you know, have been better at looking at a lot of these things that we typically hear. You know, Americans want things quickly, we want it fixed, we want to take a pill, we
Yes.
want to, right, don't we? We're
Yeah.
very impatient, and it's hard. I think you've got to do something, for 6 months or 6 weeks or whatever, to change the rewiring of your brain
Right.
to do this. But she makes an excellent point that this is, and we need to remove a lot of stigma around things.
Correct.
Depression, anxiety, mental illness, all of these things. If somebody had cancer, you say, oh. If somebody says, you know, I'm struggling with stress, you say, well, you don't look crazy. What does crazy look like? What does crazy look like? But it's easier to identify Parkinson's and cancer and diabetes and things like
Yes.
that. But we need
Agreed.
to take the veil off of that, the stigma around a lot of these things, to say, I'm struggling with whatever. It's okay. It's okay.
Now, Dr. Ash, when it comes to an effective approach to prevention and treatment, now, especially when it comes to relationship, let's say you get a case where a husband is going through addiction and the wife has to deal with his addiction. When is it okay to push forward, or when is it to say, you know what, this is a lost case?
So, great question. So I think framing what's going on is important. So what are the circumstances behind it? So we talked about stress. Stress is really the fuel to the fire of addiction, because it sort of utilizing drugs as a way to sort of escape that stress. So it's a positive reinforcement. So what happens, I think it's important to understand, what happens with opioids in particular is that we all have a reward pathway in our brain. It's meant to reinforce certain behaviors, so food, reproduction, etc. So it's meant to feel good, so we reinforce that behavior. So if your team wins the Super Bowl, the dopamine in your brain goes up 20 times. With opioids, OxyContin, heroin, it increases 1,000 times. So say you keep using that, it resets that reward set point to higher and higher and higher. So then normal activities, going to your kid's baseball game or etc., it doesn't do anything. And stress makes one want to use further to get that dopamine level up. So what's happening in the brain is that reward pathway is ratcheted up. Now nothing else meets the needs of that individual other than the drug. To say, as Bob was saying, to say that you can just, hey, pull yourself up by the bootstraps, that doesn't change the physiology. Over time, that reward pathway, which is in the more emotional part of the brain, starts to override the more rational human part of the brain. So judgment, decision making, all these things go out the window because now that limbic system, emotional part of the brain, has precedence. That cannot be just fixed with a couple of bouts of counseling or a couple of medications. It takes time, and a lot of these people are using these opioids or other medications for years. It's not going to be 2 months, go to detox, you're done. No, those rewiring and structural changes take time to get back to baseline. So medications and counseling are effective to rewire that brain, but it's a chronic process. And I think that's what I would explain to family, and I always try to have family in on the conversation. It's not going to be a quick fix. Don't feel that they're a failure if they relapse. This is what the disease is. You've had a change in the brain occur, and it can't just be changed overnight.
Wow, that's really intense.
Well, we expect, I mean, to add on to his point, so my son was in rehab twice, and I think when you look at rehab, you look at, and it's typically categorized as 30 days. I mean, 30 days is a mild detox program at best.
Yes.
There's no way, as Dr. Dewan said, you're going to rewire the brain in 30 days when it's been susceptible to these chemicals for all of this time. And in part, to answer your question, I have a friend who's gone through like 7 to 10 rehabs with her ex-husband.
Okay.
Finally got to the point where drew the line and said, I can't do this anymore. And I'm
toxic.
talking about rehabs that were like Malibu, $100,000 a month, kind of stuff. Tremendous amount of money. They have the resources to do it, to do private pay. And there's a huge money grab out there. I mean, we've got to look at where this system is broken and the corruption and all these things and that as well. But I think what these families don't understand, and I'm not advocating, a lot of this stuff is subjective. We all have different thresholds. Is 3 times a rehab failure enough to break the marriage or the relationship? Is 5, is 7? Who knows what it is? Everybody has different set points and different breaking points. But as Dr. Dewan explained, I think families don't know. Again, we acquiesce the treatment. We put our kids, I was saying earlier, on a train, plane, or a bus, or a husband, or our wife, or whatever, and we send them off. And we kind of close our mind to it. We expect they're going to come back and they're going to be better. Yeah. They're going to be fixed. They're going to be cured. Okay? And they're not, quite frankly. But we don't know, as the significant others, what to expect. We've got to set reasonable expectations. And so if these two are my therapist or part of my team, and it's a team approach, to say, listen, this could take 2 years, 3 years, 5 years. It could take, 15 times. We've got to set those realistic expectations, because otherwise we put them on the bus, we think they're coming back, and we think we're going to get the old person back that we knew.
But what about the person who's going through therapy or going through the program? Do they feel that this is going to be a waste of time? Or are they optimistic that it's going to work?
I can only answer that as a layperson. I can't address the physiology of that whole thing there. These two do a better job there. But I will tell you, based on my reading and based on my personal experience, and please correct me if I'm wrong or add on if you agree with me, is they're different people as well. I mean, you're right, the drugs have altered them to the point that really all they live for is that. That's all they live for, because as Dr. Wan said, that next high, that dopamine level or whatever. And so their focus is really that I would say, I'd use the term, they're not really thinking clearly, if I could put it that way.
So what's particularly dangerous, if I can make a point, is that when we're speaking of opioids particularly, initially it has a positive reinforcement, because you take them, whatever opioid, it causes that burst of dopamine in the brain, and there's a positive reinforcement. But really the problem is, over time, there's a negative reinforcement. If they do not use, now they're miserable, and they know that all you need is to take a hit or shot or whatever, pill, and it can all be better. So it's that negative reinforcement along with the positive reinforcement that's really the problem. And then if they can't be stabilized, they're in withdrawal or they're depressed or the other thing, now you're really creating issues. So that's why, it's interesting, those rehab facilities, it's not that they're wrong. It's not wrong to have a short-term 1-month rehab, but they have a dubious distinction of having a 100% failure rate.
Wow.
Because it's not a short-term disease. It's not like you're given an antibiotic for a pneumonia. That is just the start. And then there's maintenance and medication, well, I'll get into later, medication-assisted therapy, which is the gold standard. But that's right. So that's why it doesn't just, there's no quick fix.
Maureen, would you say that, you mentioned about PTSD, in some of your patients, would you say that most of them who deals with the post-traumatic stress disorder will go and use opioid to be able to try to cure it, to try to feel better about themselves?
I mean, I think some may do that. You know, a lot of people that have PTSD, like they have an enormous amount of pain emotionally, or you know, I have clients that are in a lot of physical pain that have addictions that actually cure that pain while they are, you know, when they have a gambling addiction or a sex addiction, you know, it takes that pain away from them. But I think that we have a tendency, as we were talking about before, we need immediate gratification and immediate satisfaction. And when we take drugs, you know, the pain immediately goes away.
To
you
come
know,
back
rather
soon
than,
after.
yeah, and working through it and doing therapy and everything else. I mean, that takes a lot of work and time to do that.
Now, I know that you were talking in one of your posts, Bob, that now a pharmaceutical company created the opioid, and now they're doing anti-drugs, or kind of like a drug that fixes this addiction. So they get the both part of the spectrum here. So what is your take on that in terms of like trying to fix a cure from a problem they created themselves?
Well, I think there's some great drugs out there, buprenorphine and some other things that Dr. Dewanka talked about in better detail from a medical perspective. That there are limits to how much of them or how long you can prescribe those things, and so I think there are some. Listen, this is not about saying that drugs don't work, because drugs have their place in our society. They do, but it's just managing those things effectively. When what you're referring to is the Sackler family, and let's put it out there, they're being sued all over the place, and they should be. I think what we're seeing in the problems with big pharma is what big tobacco was 10, 15, 20 or so years ago. I really, really do. For those people and the emails, I'm not telling anything out of school here. It was a marketing campaign. It was a marketing campaign, and it's amazing to me what you're able to. And you guys correct me if I'm wrong. For example, there's no cure for cellulite. And yet you can see there's certain creams or whatever that say, and I have doctor friends who use it and they know it doesn't work. But so what you're able to get away with in terms of marketing, based on the FTC, I think you've got to, and a lot of times here, I'm going to use the term, follow the money. Follow the money. I mean, we love our drugs, we love our money in this country, and usually, there's that financial gain there, and I think we need to trace it all the way back to that. But again, a lot of this is awareness. We really acquiesce care, and it's. I've just lost my son. Yeah. I got to tell you guys, I've lost my parents, I've lost my brother. It doesn't get any worse than this.
If you go back, and because you just mentioned the tobacco companies, Philip Johnson, which is the largest producer, now when you look at the cigarettes, the pack, you see in big bold, it will cause cancer. Do you think that 10, 15 years from now, Bob, pharmaceutical company are going to put also in the bottle, be careful, that's going to create addiction, that's going to create this, and this.
It's a great question. And maybe
I mean, if you look at what Philip Johnson did,
I mean, it's a great question.
Do you think that is going to be what we should expect pharma company to do?
So I think it's complicated in that it's not that all opioids are bad, it's how they are utilized. But certainly, and the onus is on the physician, but also on the marketers, that there is the risk of addiction and misuse with these types of medications. That what I do when I see a patient who may be a candidate for opioids, we always do a screening, like it's an opioid risk tool. Are they a type of patient that could be prone to addiction? What is their family history? Have they had IV use before? What kind of stressors do they have? What is the propensity that they could abuse this? Then they may not be good candidates. So
I see.
So it's not that the medicine itself is bad, it's that we don't, and that's what we have done as a profession, unfortunately, we haven't done good enough a job, is pre-screening for patients, seeing if they're a good candidate, and then also, what's the end point? I mean, at what point do we think we can get off these medicines? For me, we try to fix what's fixable, manage what we can, and then if things are going okay, try to wean, give an expectation that we're going to try to get off. If we do that, I think we're okay, but that hasn't been the case.
But our doctors, psychiatrists are willing to be able to do that extra step versus just, here's a prescription, because in the back of their mind, I know I'm going to get some money out of it.
So so that's a great question. The thing is that most physicians, and I was one of them, so I can speak from it, learn nothing about opioids in medical school or in residency. It's only after I trained additionally that it all came to light. So in some ways, physicians should not be prescribing these medications if they're not equipped to. The problem now is, and why I think it's not just on the supply side, that you've had so many patients been on opiates for so long, and now a lot of physicians are just withdrawing care. And now what's to happen to all these patients who have been on these medications for years and years, sometimes decades? Where are they going to go?
You send them to Maureen. Here you go.
So that's really sort of fueled a lot of this epidemic, and why there is so much illicit use. It's not always that they're addicts trying to do harm, it's because they've grown dependent to the medication. And I always like to make that discrepancy. If you're on this medication long enough, you become opioid dependent. But that does not mean you're an addict. Addiction implies use despite harm. A lot of these people aren't using. I have classic cases, a lady who came to me after a breast surgery. She had a breast cancer, had some neuropathy from the chemo. She was placed on high-dose fentanyl the patches, and then when the therapy was withdrawn, they just stopped her on the medication. Well, now she's in terrible withdrawal, terrible pain, etc. So she came to me, I stabilized her. Within a few months she was off. That was one of the most rewarding cases I've had. But I tell you, most docs wouldn't know what to do with this, and that's part of the problem.
So what do you prescribe to weed them off?
So it depends what they have been on, but if they've been on high doses, I use buprenorphine. The key is that, and again, it's not the only medicine out there, but it is one chemical that when it binds to the opioid receptor, take for instance methadone or oxycodone or anything like that, when it binds to the receptor, it opens that door to the brain wide open, and there's a big rush of dopamine. And then it wears off, and then people go into withdrawal. With buprenorphine, it's just a partial agonist. So when it binds to the receptor, it just cracks the door open about 25–30%. Enough so that they're no longer in withdrawal, but they don't get a full opioid effect. Now we can try to gradually wean them down so they're safe, they're not in withdrawal, they can't overdose from it if they've already been on opioids, and now they can be normal. And so that's what one of the techniques I use to get people down and off. Now, if there's an addiction issue, that's when I need counseling involved and additional therapy. So it's not such a quick
fix
thing.
Yeah. For you, Maureen, when you've dealt with people who've gone through relapse, usually this period of time, how do you cater to their needs, or how do you help them go back to recovery? Because it's kind of like, for them, is it more of a physical or mental failure that they've gone through this process?
I think for a lot of the clients, it's really a mental failure. And I think the number one thing that they need to do is forgive themselves for relapsing. And it's okay to make mistakes, and it's okay that you have to start all over again. But you can do it. You did it once, you can do it again, you know? But I think that we need to encourage a lot and really point out a lot of the positive things that are happening in people's lives, because we do have so many negative things going on. And people that are addicted, you know, to drugs or alcohol or whatever, they see a lot of the negative in their life, you know, and they use this to kind of push that away. So relapse is really just about forgiving yourself, I think.
Now, if let's say you cater with food addiction, with anyone who suffers from obesity, do you deal with them the same way as those who are taking drugs?
Same. Yes.
Okay.
Because food for them is a drug. You know, I mean, that's what they're fulfilling themselves with when, you know, that makes them feel good. Yeah. Same with sex addiction, same with gambling addiction. You know, I mean, whatever it is that whatever event that they're doing, that's giving them that high.
Okay. And the high that they're seeking, are they seeking more positive acknowledgement to say, hey, you did a good job? But then when they relapse, is it a bigger fall for them?
Absolutely. Absolutely. Because I mean, they've done the work. They've put all this work in to getting sober or getting better, you know. And now when they do relapse, it's just a moment of weakness. But it's okay. That happens. You can go back and you can do it all over again. It doesn't mean that you'll forever be, you know, addicted.
Typecast.
Right. Right.
Yeah.
Interesting.
Right.
Now, would you say, Bob, that addiction is a full-fledged disease?
Absolutely. I mean, I think when you look at the studies, and Dr. Dewan's done some good work on this, and we've talked about it on my show, I mean, addiction is a disease. You know, it's interesting. I've applied a lot of these things to myself. I jokingly say, I get motion sickness. I can't even do roller coasters.
Me too.
And so, but I would jokingly say I can never do drugs because I can't even do roller coasters. I mean, I don't like that sort of swirling around or whatever. Not that all drugs do that to you, but I've never, you know, and most of us have probably smoked a joint at some point in our teens or early 20s or whatever. And I don't have an addictive personality. So I think also too, people have different receptors, and and these things are processed differently and incorporated differently. And so, you know, I think what we're talking about here, a couple things I want to follow up on Dr. Dewan's point about, you know, you give somebody an MD or a PhD or an MPH or whatever, and you put them out there and you give them the legal permission to write scripts. That's dangerous in the wrong hands. I think you'd agree with me. You know, but we do that in a society. We salute that, we acknowledge that, we reward that. But there's a lot of ignorance. I'll use that word. Whether it's in medical schools or residency programs, you've got a lot of people out there that a script in their hands is a pretty dangerous thing. And to Maureen's point, I think, you know, the positive reinforcement, I think we need to look at this from a team approach. The family needs to be more involved. I'll tell you guys right now,
yes.
as a layperson, and when your viewers are watching this, folks, if you're out there, make sure I go to the right camera or go to you, it is a team approach. You need these guys on your team, but the family needs to be very involved. Stop acquiescing care. If I had to dial it all back, and my situation was complicated. I was divorced from my son's mother, so there was no communication. Forget the breakdown in communication. That contributed to a lot of my son's problems. So we've got to look at the ancillary things that contribute to the problem anyway, and deal with those things. We don't do a good job of dealing with these things. We don't, you know, I can remember, you know, one recovery was in Dallas, another recovery was in Florida, and I remember when my son came back and then went into maybe a sober living home, you just kind of like take them there and drop them off, and again, just hope they're going to come back fixed. And it's almost like the Wizard of Oz, what's behind the curtain? Don't look behind the curtain. There's a lot of truth to that, I got to tell you guys, you know, that we do. We just, and some of us maybe don't want to know. You know, the drug world and that whole thing, that culture and all of that, it's its own cottage industry. I mean, it's a multi-billion-dollar industry, the money that's in that. So a lot of us just don't want to know. We don't want to know. But when it comes to our loved ones, we have to know. We have to know.
I agree. This is like for all of you, what would you say the success rate is for intervention? Let's say the person who is dealing with drug addiction or food, and you get the family involved, as you mentioned, Bob. Do you feel that this is something that can work because they feel that the family is involved, that they care, and that will have a better approach for them to succeed in their recovery or and to avoid relapse? What would you say? Have you done intervention in your practice?
I have not done interventions within my practice.
Okay.
No.
Have you, Dr. Ash?
So there are many levels to it, because as with any disease, I mean, some people have a greater severity of disease and some have less. Just a quick point about this relapse. The way I view relapse is a symptom of the disease. It's just an indication to intensify therapy. That's all. Intensify treatment. So as long as, and I think intervention is good as long as we lay the expectations down, and it is a coordinated, as Bob said, team approach. Medication is good for stabilizing a patient medically in terms of cravings, withdrawal, and making them, you know, feel normal. But it is not the only answer. So we always do, whether it's cognitive behavioral therapy, motivational interviewing, other counseling that's an integral part of that treatment. And then eventually when they are weaned down on the medicines, they have to have the coping skills that they learn through counseling on how to deal with stressors. So the next time they encounter that, they don't want to, they may get cravings, but they won't use if they've gone through this program.
Is there like any, like if you treat someone, for example, Maureen, can you know that someone is prone to addiction?
Just by looking at
By
them?
talking to them?
Sometimes.
Okay.
I mean, it's hard because, you know, I think therapists, we're trained to notice certain things about people, but sometimes you would never know, ever.
So they have to
People had
bluntly tell you
addictions.
that I'm using this drug or that drug and I've been addicted for several years.
Exactly. We can't assume, because that's not the correct
No,
way to
correct.
do. But yeah, I mean, you have to let them, you know, bring it out. But I mean, I agree with you. Like, we don't teach people coping skills. We don't teach our kids coping skills, you know, and the teenagers, you know, I mean, people growing up, you know, it's the quick fix for everything, and they don't want to talk about what's going on, you know, to get to the root of everything. So then they self-medicate a lot with alcohol or drugs.
Dan, this comes back to my platform. It comes back to communication. And I think so, whether it's drugs or therapy or religion or whatever, we just don't do a very good job of communicating. We don't talk about what we want, what we need, and how we feel. We live in fear. Gandhi had said it years ago, and I put it in my book after I found out that Gandhi said it. But we live in fear. We live in fear of rejection. We live in fear of embarrassment. We live in fear of confrontation. If you and I are married and I say, hey, I'm struggling with this, and this new book that I'm reading, Broken, by William Cope Moyers, he hid this whole addiction from his parents. He hid it from his wife. He would have nosebleeds, and he would make up some kind of an excuse for that, and she believed it all. And I think here's another part of it too. A lot of times our significant family members want to believe. They don't want to acknowledge that you could possibly have an addiction or a problem or be on drugs, and so they want to believe these things. The excuse you make up for why I'm having a nosebleed all the time, because people don't want to look at these things. And it really,
Correct.
Dan, it comes to, I can't say it enough. It comes to, and I apply this to, a little bit of my background.
Yes.
My book is my personal story. I've put myself under the telescope or microscope or whatever, and said, why did these things occur? Because we don't communicate very effectively. We're afraid of a lot of things. We really are.
I agree.
And particularly as we age. I mean, look at the
uncertainty,
suicide epidemic.
yes.
Life expectancy is down
is
for the
growing.
third year in
I
a row.
agree.
Suicide's up. We're lonelier. We're less connected. All of this stuff. The sense of community is gone from this country. I mean, we'd have to do another show and maybe a whole series on this. But these things have comorbid effects. They really do. And we don't look at that. And we need to start looking at that, or we're going to have bigger problems. This is not going away anytime soon, right?
At all. Now, in the case of Zach,
Yeah.
what caused the divorce? This is the reason why he got into addiction, or the divorce was the cause and the effect was the addiction, or vice versa?
Well, I think it was his processing of, here he had this, he was the eldest of four. His parents were going through a public divorce. We tried to protect our children. I had two children that were younger. He was the oldest. He was 13 at the time. And you're dealing with your own, Maureen, as a therapist, people in the midst of that are dealing with their own trauma. And we don't do it, and I'll admit to you, we don't necessarily do a good job of how's it affecting my 6-year-old or my 12-year-old or my 13-year-old, because nobody gives you the book on this stuff. I've been married and divorced twice, and I'll put it out there and share it with, and now I've taken at least a 10-year break, if not forever. But anyway, nobody gives us the handbook. How do we deal with these things as individuals going through the trauma, let alone what's the effect on those of us or those around us? And so it contributed greatly to, and everybody processes it differently.
That's
I have
correct,
4
exactly.
kids through that relationship, and they all process it. I think you would
Right.
agree, right? Everybody processes trauma differently.
Absolutely.
Well, we all have learned in our psychology book during our degree. How much of it do you really apply, or do you just use personal instinct to be able to solve your patient's problem?
So, I mean,
How much customization do you have to do?
I don't think I'm as good as picking it up just from interviewing a patient as Maureen would be, but I do ask those questions. I think one of the big problems with this epidemic is, about 60 to 70% of patients with addiction have seen a physician within the past year, but that doesn't mean that it was ever brought up or that it was ever screened. So that's why only 10% of people with addiction are actually being treated. So what we need to do a better job of is actually screening for it. Now, we were talking about, can they be anybody? I mean, they can be anybody. I mean, they can be the physician, the lawyer, the soccer mom, the affluent, etc., or the tree worker, or whoever. So I've seen it all. And in fact, a couple of my partners were like, I don't know if we want those kind of patients in our practice. And well, guess what? They're already in your practice. They're your patients that are coming to see me. So you can't really judge a book by its cover, and you have to actually screen for it. And it's because of the negative stigma that they don't seek care and the physicians don't screen for it. If we do that, we pick up a lot more of these patients, we get them in treatment, and we can preclude a lot of the problems that come forth. I mean, with Zach, I'm sure it was more the stress of the divorce that led to some sort of seeking of relief for it. So it's probably not a direct cause, but again, it's that stressor that people try to relieve. So counseling early, screening for substance abuse before is the approach that we should use now.
Yeah.
I read a very interesting article, and maybe you may just contribute to let me know if this is what you really believe in. There was actually a story where a woman was suffering from rheumatoid arthritis. She went to the doctor and she filled a questionnaire, and then she said on the section of mental illness, she said depression. Okay? So the doctor, when he kind of like discussed with her all the symptoms, he said, "What are you depressed about?" I said, "Because of my pain." So physical comes before mental. So would you agree that if you fix the physical first, people's mental illnesses will not cause any of what we're dealing with depression, with any other issues that people are dealing mentally, because they're really inside they're dealing with a physical illness. But doctors are not really digging deep enough to find out what is the physical problem. So what comes first, mental or physical?
So that it's a chicken and the egg, right? So
Yeah.
because I also am a pain physician, I do a lot of chronic pain. One of the first things I do when treating a chronic pain is address the depression. Because who will not be depressed if they're completely limited by pain?
Correct.
So that's almost a part of the treatment. In fact, that's part of the treatment for their pain is to treat their depression, because they're not moving, they're not active, they're not doing anything, they're not exercising, they're not meeting other people. So that actually worsens the pain. So that is an integral part of treatment for substance abuse and for chronic pain. So again, we have to screen for it, especially in that high-risk patient population.
But do they really actually take the time to do that? Or they just in their mind, I'm just going to dump them with pain medication, hasta la vista, baby?
You mean the provider?
The provider, yes.
Not take the time.
No, they don't.
Bluntly, yeah.
They don't.
Okay.
Well, I remember, and Ash, you might remember this, when we did my show, and I had him on my show, and I said, somebody comes to you and says, "Hey doc, I'm struggling with whatever. What do you do? What's your protocol?" And he had the right answer, and I know he believes this. You go through that screening, that pre-screening. I would say he's the exception to the rule. Certainly there are others out there, and I've been around medicine. My ex-wife's a physician. I've been around medicine for about 30 years. There are good docs and bad docs, and there are good lawyers and bad lawyers, and there are good preachers and bad preachers. We just have good and bad, and I don't mean that in a really pejorative way. You know, we're talking about ignorance, lack of training, lack of education, different motivations. You know, this is a guy who I've been very impressed with, who's very motivated.
I am impressed too, actually.
We have a big problem, and he and I have collectively come together in some solutions and are collaborating on those things. I've been I will tell you, I always say this to you, and maybe your viewers will be taken back a little bit, my closest friends. I've been inspired by my son's death. You know, when we have tragedies like this in our lives, you can go one way or the other. You know, some people fall apart, and if you're out there and you're listening to me and you've lost a child, I get it. You know, and I've had people come to me and say, "I don't know how you get out of bed in the morning. Some mornings I don't want to get out of bed, but I'm a warrior, I'm a fighter, I need to do something." I'm also very spiritual, I believe in therapy. I've done a lot of these things prophylactically, you know, where I've been doing therapy before I even had any trauma, and arguably we all have trauma to some level. But these are all the arrows in our quiver, Dan, that we need to have to make us stronger. I feel very inspired to make a change in the world and the way we look at addiction, treatment, and recovery. What we're doing is not effective. Look at relapse, look at the money, look at all of the problems, look at the death rate. But we keep doing the same thing over and we expect different results, don't we? So I tend to be a pretty simple guy. It's like, let's find the source of where it's not working and let's attempt to make some changes there and fix that. And I just don't understand a society that can't do that. I really don't. We've got the money, for God's sake, we really do. So why don't we do it? What's the impediment to making that?
Well, as Dr. Ash said, it is probably because everyone deals with addiction differently.
They do,
Everyone cope with addiction, and one person, you know, they may not think the same way as the other. I mean, it seems like more your linear situation that everyone who suffers from this drug addiction, if you give them that, everyone is going to fix the same way. Unfortunately, it's not the same. It doesn't work that way, unfortunately.
There are still some standards of care
that
we need to apply that can be applied to every situation. The way people process it is differently, but as you know, Dr. Dalam is saying, you know, he's got this intake basically. that can apply to everyone. How you process those things and how you answer it. If you choose to be open about it or lie about it. And let's face it, with addiction, there's a lot of mischaracterization. There's a lot of
Denial.
lying and covering up that goes on. That's another problem.
Yes,
okay,
correct.
That really is. So you ask the question, they give you the answer. Is that the right answer?
No, unfortunately.
It's a huge part of it. But I think there's some standards of care that we can apply to this to say this is the way we do it and deal with those triggers. When we know that the lying and the stealing and all the other things go along with this, unfortunately.
But do you think that what's missing the most, it's self-awareness? If they're self-aware that they have a problem, they do not deny it, they're open about it, they discuss, they communicate, as you mentioned, do you feel that this can be a big help for people recovery?
I don't think they're capable of that. Would you say they're capable of
Yeah,
self-awareness?
that's a great question, because it depends on the severity of their disease. You know, early on, they may seek help, but again, there's that negative stigma. I think we are where we are in addiction, where we were with depression in the 60s. I mean, it's really, and it's not that a lot of these docs aren't trying to do the best job they can, they're just not equipped for it because they've never been trained for it. They're busy, they're trying to move along, and so it's difficult to address all those problems, and so they're just trying to, go to psychiatry or go to, it's not so straightforward. But again, screening on our part and awareness on the patient's part would go a long way to helping.
I think sometimes too there's a progression, with the addiction. It starts off small and it's just hanging out with your friends and it's a social thing, and then it's like it becomes more and more. And before they know it, they're just,
They're in deep.
they're in deep, and they just don't know what to do about it. And then they're a completely different personality from what they used to be. So I think sometimes it takes them, off guard too.
So how many cases do you deal like when it comes to some form of mental illness in your practice, like with addicts? I mean, what kind of approach would be the most effective and that you have seen among all addicts?
I think, again, like going back to like, what is the root issue? Like what is it that you're trying to escape from? What has happened in your life to have this sort of trauma? I mean, I think all addicts, I think their families experience PTSD. I don't think it's just geared just towards, like certain careers or, situations. I think that we all have these like big traumatic events that happen in our lives that we just don't know how to deal with, so again, it's just, the immediate gratification. I just take this away, just take it away, even if it's just for a moment. Yeah.
Dan, I wanted to share that there was these studies done. It was on chronic pain, but patients who had been on opioids for a long period of time. They did a functional MRI of patients who weren't on opioids and then those who were on opioids for an extended period of time. What they found was that, again, I mentioned earlier, that limbic system, the emotional part of the brain, was a certain size in non-addicts, and their cortex was thicker, the human part of the brain, which emphasizes judgment and decision-making. In patients who have been on opioids for a long period of time, that cortex actually thinned, and the limbic system had hypertrophied. So it emphasizes that it is a real disease. Just even structurally, you can visualize the changes on MRI. Then they looked at patients who got, these same patients who were taken off or weaned off opioids, or who were in counseling, whether it's meditation or et cetera, different kinds, and actually that cortex increased in size. So it correlates structurally and functionally with recovery. So it's an actual thing that we can visualize, not just hypothesize.
And is it reversible? Which means that how long does it take for it to go back to its initial size prior to getting into addiction?
So every patient is different and it depends, but meditation has been one of the big things to help with that, as well as weaning off opioids. That was shown to actually restore those normal connections. So, but as you know, it can be years, and it's different in every person. So again, it emphasizes that you cannot just expect 3 months and you're fixed. It has to be a long-term deal, and long-term counseling, and sometimes long-term medication. And nobody's, nobody asks how long you're going to stay on your diabetes medicines.
Yes.
But they ask how long you're going to be on your. The answer is not to get off the medicines; it's to prevent relapse and to ensure function and good health. So some people are longer, some people shorter. As long as there's a movement towards that, then we're in good shape.
When we go to like family dynamic, Maureen, drugs with children affecting the parents or vice versa. How much of those cases do you see on a regular basis?
A lot. I mean, I was MCPS counselor for about 9 years, and I saw a lot of drug use by the students, you know, parents that affected the students negatively. I think that children, like, really, when it affects the family, the children take on like the parental role, you know, and then they have to, I mean, I've had kids before that had to raise their little brothers and sisters, you know, get them off to school, and then in turn they were late for school every day because they had to do that, you know, and we really don't look at the underlying cause of what's going on sometimes in people's lives, because we either don't want to pry or we just don't have time to ask. And that's why I really tell people, like, you have got to open up and talk about things, you know, especially if you're going through a hard time. There's so many resources out there for people. And then again, I mean, the kids doing the drugs, you know, it's so rarely accessible to them. I mean, there's a lot of drug dealing going on within the schools.
Oh yes, that's a big problem as well.
You know, and it's just kind of like getting to the next high, the higher, the higher, the higher.
As you mentioned,
know?
Dr. Ashram.
Yeah.
Okay.
The early age of use and also the type of drug used is one of the big predictors of, you know, really having severe addiction.
So if you had to kind of like give a magical solution to the whole opioid epidemic and the drug problem, what would you suggest first to tackle?
Wow. Another great question.
It's a big one, I know.
Number one, we must recognize that there's a huge treatment gap between addiction and other chronic diseases. So we must screen for it. We must decrease and eliminate the negative stigma associated with it, and emphasize that it's a huge problem, public health crisis, that we've got to get people into treatment, number one. So get them into treatment. Once they're in treatment, we must stabilize them medically, because they will undergo withdrawals or cravings, and that's going to make them want to use more than anything. So if you can stabilize them medically, now methadone is used, buprenorphine is used. Buprenorphine is far superior in that it is much safer, it is not a full agonist, it doesn't make you high, and you don't get tolerant to it. And then along with medication-assisted therapy with counseling immediately. And then get them, and set the expectation that it is not going to be a quick fix. One thing I would like to make a point with, you know, I don't know how this came up, but the politicians make the call, but any physician can prescribe as much methadone to as many patients as possible. Now, methadone is only done in a clinic. It is so cumbersome for a patient to live a normal life and work to have to be there every morning, and they're around people who have the severest disease. But buprenorphine, which is an office-based, which physicians who are addiction board certified, you can only treat up to 275 patients, period, throughout the country. So it makes you wonder, if you had a great diabetes medicines, it's going to do great, get everybody's sugar normal, but you can only see 275 patients. Is there any logic to that whatsoever? So that's one of my big beefs, is that for people who are qualified and integrate counseling into treatment, why limit the number of patients one can see in an outpatient setting, which is convenient and readily accessible, for docs who are just doing, you know, doc in the box and not doing any counseling? Not only should they not be seeing 275, they shouldn't be seeing 5 patients. They shouldn't be seeing any. But for patients who are who can access treatment successfully and are in counseling, there should be no limit to the number of patients that a doctor can help. And I think that would go a long way into getting more patients. Like I said, 21 million people are addicted, 2 million are in treatment. That's a huge problem. We need to get people in treatment.
Do you think if insurance companies will cover more of the expense, that can solve the problem? Because as you mentioned about the out-of-pocket, not therapy center, but the treatment center, do you think if the insurance company will allow to cover more of the expense, do you feel that more people will go and try to get fixed?
I mean, I don't, and only because, and it goes back to the point about awareness and education and medical providers. I mean, insurance is a roadblock to some of these things, but first we've got to get people to recognize there's a problem. We have to do proper screening. We have to get them into the system before we can allow the system to work. Certainly, you know, a more liberal insurance plan. But the one thing that Dr. DeWan talked about is it seems to me that we've got the wrong people making the rules.
I agree with that.
You know, I mean, so if we've got a problem and we know that this particular drug helps, why 275? Seems to be an arbitrary number. Who came up with that number? Is this an actuary who's sitting there with a green shade on who suddenly has decided? I mean, it seems to me that we've got the wrong people making the rules. I live a large part of my life out loud to help other people, and so for people to see by example, and I'm not afraid to share it, and people call me brave and this and that. I don't really see it that way. I really see it as an obligation. I see it as a blessing in a lot of ways, and I think I'm encouraged and I'm also discouraged. I mean, this is an enormous problem, but I think we've got some solutions to it, real solutions to it, and I know in the case of Dr. Dewan and I, we're not going to stop talking about it until we see real change. There must be real change. I've got 5 children that were left on this earth. I've got 2 grandchildren. Life's complicated. Maureen talked about it. I mean, life's complicated and tough. Social media is impacted. We could do a whole show on that. I think you probably have.
Yeah.
Life is tough and it's challenging. It really is. And not everybody is equally equipped to deal with the traumas of life as the next guy. But we need to make it okay. We need to make it okay to struggle and to have these problems. It frustrates me, Dan, when I just see the same old thing being done, and the problem's getting worse.
Yeah.
Life expectancy down 3 years in a row, suicide up. That is a problem. And what are we doing about it? What are we doing about it? Hello?
Well, we only have 30 seconds left for the seminar, so what would be, from all 3 of you, a quick, I would not say a quick fix, but more of a quick advice for everyone, all of our listeners out there, to say who's dealing with addiction, what they need to do now?
Destigmatize addiction, get people in treatment, and ensure that they're in treatment for long enough so that their disease is managed.
Maureen?
I'd say don't be afraid to trust somebody with your issues and kind of they can handle it, so just reach out to a therapist and you'll be okay.
Well, not just a therapist, Maureen.
A therapist.
Okay, good. Excellent. What about you, Bob?
Talk about it. Talk about it. Make it okay. Communication. I'm struggling with this. I need help. Make it okay to ask. We all need help in some aspect of our life, and so talk about it. The communication comes down to the communication.
Beautiful. Well, folks, that's all the time we have for today. I would like to thank my guests for attending today's seminar. Their contact information is provided on the lower third of your TV screen, as well as a credit at the end of the show. Now, here are a few concluding words of wisdom related to addiction and recovery. Many people don't realize that they have an addiction to a substance until they try to quit. One of the harshest realities is to acknowledge that you have an addiction. While this chapter in your life may be scary, know that you're not alone. Plenty of others have gone through the same process and they know what you're going through. Addiction is just a way of trying to get at something else, something bigger. Call it transcendence if you want, but it is also like a rat in a maze. The thing you think you want offers some kind of relief from the challenges in your life, but it is a trap. Do not fall in it. Though no one can go back and make a brand new start, anyone can start from now and make a brand new ending. We're all sending our wishes and condolences to everyone out there struggling from addiction and the one who have already lost their battles. Our hearts are with all of you. My name is Dr. Dan Amzalag, and may you find peace and serenity in every single day of your life.